Good afternoon, everybody. Welcome to the RESNA position paper on the application of 24/7 posture care management feedback session. We are so honored that you're here to help support us in writing this position paper by providing feedback, and we're just so very pleased that we get to all be back together in person again. I'm Patricia Toole. I'm an occupational therapist and a teacher, and I've been doing seating and wheeled mobility formally since 2008 and posture care management since about 2015. But I think you could also say that I've been doing both postural care and seating and wheeled mobility since my son was born in 1998 with spastic quadriplegia. So I have the therapist hat to wear and I have the mom hat to wear. And I'm just very pleased to introduce the rest of our presenters.
Hello, I'm Tamara Kittelson. I'm very happy to be here as well. I've been involved in doing seating and wheeled mobility since 1985. Yes, I am kind of an old therapist. And posture care management since 2000. I ran a pilot study called the Montana Postural Care Project and recently published a case study. And currently I'm consulting and teaching in this area, but the real inspiration for my work is my daughter Eleanor, who was born in 1989 with CP and has gone on ahead of us.
Hello everyone, welcome to our session this afternoon. I'm Hoffman. I'm a posture guardian and they let me teach occupational therapy students. What were they thinking?
Hi, and I'm Jenny Hutson, and I too teach occupational therapy students at St. Catherine University in Minnesota. I also worked at Gillette Children's Specialty Healthcare since 2002 up until last year, specifically in seating and positioning for wheeled mobility and also other assistive technologies. And then I started working on line postural care, doing mostly research-related projects in 2014.
And I have the pleasure of introducing Kourtni, the fifth member of our work group. She is expecting her first baby in June, and so she's not here with us today. But she is an OT in Madison, Wisconsin. While she was working on her OTD, she completed both her research and doctoral work in lying postural care management. She credits her nephews, Carter and Bastian, for teaching her the importance of posture care management in all positions. And we have no conflicts to disclose. So why are we doing this? We've got our objectives, which all of you would have read when you decided to come and see us today. But we want to be sure and share that we have really evolved in our language since we needed to submit these objectives last year when we submitted our abstract. We now speak about individuals who cannot independently and easily move in and out of symmetry in supine. And this typically is going to include people who use wheelchairs, but it actually describes the population a little more precisely. So when a group is writing a position paper for RESNA, we are required to obtain feedback during the process, and that's why we have all of you here today. This is our feedback session. We're going to be reviewing the content areas, the terminology, evidence, candidates for using this intervention, and case study descriptions. And we are going to be eliciting feedback from all of you in this room. So be ready to share your thoughts when we give opportunity. And we do have somebody who will be taking notes so we can incorporate all that we hear from all of you into the final draft. Now, a RESNA position paper on clinical practice is an official statement that RESNA stands behind and summarizes current research and best practice based on consensus of experts and evidence. So it declares the necessity of specific assistive technology and services under appropriate circumstances, and it's designed to guide practitioners in decision making. So why are we doing this? We are doing this because there are many already existing RESNA papers that discuss postural support in sitting and in standing, but there is nothing that's talking about postural support in lying.
So I just wanted to take a minute and just highlight how the pieces of a person's day fit together. So 24-hour posture care management includes not only supportive wheelchair seating, which I'm sure many of you are expert at. Do I still have that? How about now? Oh, lovely. Okay, so supported wheelchair seating, support in standing. It's gone again. All right. I'll just hide behind the podium here. Positions of rest and supported lying. So I think it's really important to see how these 4 areas fit together like pieces of a puzzle to create a 24-hour clock during which the person receives appropriate supports at all times. So right now, I'd just like you to think of a particular patient of yours. And as rehab professionals, OT, PTs, rehab engineers, physicians, and others, we understand that the human body adapts to the demands placed upon it. Muscles that work to propel a wheelchair become stronger. Backs, hips, and legs can become overstretched from low load, long duration stretch in unsupported positions, or can become contracted from slack positions without significant variation, leading to unnecessary secondary complications such as disturbed sleep, pain, and even bony changes. So on this understanding and on the functional daily needs of wheelchair users, we provide excellent support for sitting and standing. I'm assuming we are all here because we are really good at wheelchair seating. But sometimes we forget the rest of the day. And so I want you to think of a patient and think of how long you would estimate they spend sitting in their spectacular wheelchair seating that you made for them. Can I get somebody to volunteer? How much time? 5 to 8 hours. Anybody have longer? Yeah. 23 hours. That's a lot. Sleep in the chair. Yeah. Anybody else? Amount of time sitting in the chair? About 10 hours. Okay. And about how long does the person you're thinking of use supported standing? Raise your hand if the person you're thinking of uses supported standing. In the back, how long do they usually use the stander? Okay, great. And are there any other positions that you think are significant for the person? Maybe the couch or the recliner, or raise your hand if you have another position. Shower chair. Okay, that's what happens in the other hour of the day. Anybody else? Another position other than the wheelchair? Yes. Peapod? Uh-huh. And behind you? Yeah. Okay, well, I have a particular patient of mine in mind. So I did a little chart, little math. So this particular patient of mine goes to school. And so gets up and gets in his chair in the morning. And from the time he gets in his chair till the time he gets home, it's about 8 hours because of the transportation on both ends. And he's out of his chair a little bit during the day for some hygiene and some other reasons, but it's close to 8 hours that he's in his chair during the day. He gets home, gets off the bus, and his family wants to give him a break from the chair. So he gets on the couch for a couple hours. And after he's rested and he eats dinner on the couch, he does about an hour of standing and then he goes to bed. So this might be a little bit different than your patient, but it might have some similarities too. So what I want to point out to you is the number of hours my particular patient spends lying. So that works out to 4,380 hours a year. I know that font is a little small for you to see, but 12 hours a day. What's that? That's why you sat up front? Okay. Can you see it from the front row? Yes. Okay. But let's just say that your patient doesn't spend 12 hours a day in bed. Maybe they spend 8 hours a day in bed. That's still 2,920 hours. And so the numbers tell the story of the need for assistive technology for lying posture care management, just as we need assistive technology for sitting and standing.
Thank you, Trish. Okay, so I get the fun part. The fun part is, oh my goodness, how much good work has been done already. If you look at all the RESNA position papers that have been published, and I'm going to run through them now. But firstly, I'm going to ask, please, if you do want to take any pictures, please refrain from taking pictures of any of the slides that have patient pictures on. While we do have consent to share, it is the purpose of the presentation and not for other sharing uses. So please hold on the snaps. Okay, so what do we know? So from RESNA, we know that there is dynamic seating. There's a position paper that's come out about that. Ultra lightweight manual wheelchairs, wheelchairs and seating systems for secondary supports for seating versus, or positioning versus restraint. And then also the wheelchair service provision guide. Then we have more coming in the back, tilt and recline with elevating leg rest. We also have powered mobility devices for pediatric users, and then also seat elevation devices for wheelchair users. That's a lot of work that's been done. However, there's more. For standing, the clinician task force and RESNA have put together a position paper for supported standing devices, and there's also application of wheelchair standing devices. So a lot of work has been done in sitting and in standing. So you're going to agree with me that there's nothing for lying just yet. So what do we know? We know that this is a position that does work. So these are everyday items that have been used to support a client. This is one of Tamara's case studies. So if you do want to have a conversation with her about this specific client, please feel free to speak with Tamara afterwards. We wanted to highlight that this is the same day, same person, everyday items. Look at the difference that makes. Okay. But what does that look like for sitting? Well, the picture on your left has got a position of Jim prior, and then also what the impact has been on his positioning is the picture on the right. Okay, and then time between. No, about 5 months. You're welcome up front. Okay, so what does this mean? It means that all postures are linked. So look at the translation of the lying position. What does that mean for sitting? What does that mean for standing? So if we don't address positioning and lying, it impacts sitting, it impacts standing. Okay, so all postures are linked. All right.
All right, so now we're getting into the position paper, a little bit more about what it would include, and then we're going to start talking about some of the content area that we've sort of shaped so far. So according to RESNA, the position papers need to include a comprehensive literature review and a summary of the evidence. It needs to have documented best practices for an AT topic, an assistive technology topic, and its service delivery processes, and also and/or information about funding justification. And then a comprehensive review with the benefits and the application of the technologies. So thinking about various practices you can have and service delivery models you can have. So we did a lot of work over the past year to try to develop what we think the core sections of the paper would include. And in this paper, we're including the purpose and the significance of the paper. What is 24/7 postural care management? We really felt like we had to describe the big picture so that there was context to what line posture care was. So then we have what is line posture care management, who may benefit, and who is the intervention intended to be used with. Also, what functional improvements might we expect to see? So what are the outcomes? What considerations and challenges need to be addressed throughout service delivery? And then case study examples. So those are overarching content areas. Some of the information we have in the purpose section is about the purpose is to communicate that line postural care management evidence and the considerations for practice. And we will be sharing those client-based examples. As far as significance is concerned, we know that there is an association between people's lying position and their sitting or standing positions. And so we want to describe that evidence because it's significant to know that the position of lying will become or can become the position of asymmetry. We also are identifying the significant being that this will lay the groundwork for us in our industry to be able to have some standardization and protocols. So just starting that, we're starting a discussion today, but when we write the paper, we're going to start even more of a discussion. And then ultimately our hope is that we achieve better outcomes or the best outcomes we can for the people we serve. And as far as our current definition,
I just think it's so important to understand posture care management for lying in the context of the 24-hour period. So it's hard to sit still. So we've provided a definition to help put this into perspective. Just to give you a little history, we considered all previous published definitions, and our definition has evolved significantly since we began working on this. In fact, we had a much more concise and simple definition that we considered and abandoned because, how do I put this? It failed to capture the important aspect of the client-centered nature of our work. You simply can't do this work ethically and effectively without partnering with the people you're supporting and their families. There's just no way to do it well. And so it became essential that that was captured in the definition. It's embracing the spirit of nothing about us without us. And as a family member of a person with a disability, a person that I love probably more than any other person in the world, that is essential to success of this work. So our definition became a co-created therapeutic process by which a person with limited movement ability is empowered to lie, sit, and stand in increasingly symmetrical positions through skillful placement of whole body therapeutic supports. The purpose of 24/7 posture care management is to protect healthy posture and maximize the user's everyday functioning. The purpose of assistive technology for lying posture care management, like the purpose of all AT, is to enable the user's functional engagement in activities that would not otherwise be possible for them. So in my family, this is what that looks like. These are some of the functional things that we do because of assistive technology for lying. Similarly, the definition of lying posture care management needed to come into alignment with the 24-hour so that we likewise say a co-creative therapeutic process by which a person who has limited movement ability is empowered to lie in increasingly symmetrical positions through skillful placement of whole body therapeutic supports. The purpose of lying posture care management is to protect healthy posture and maximize the user's everyday functioning. And it's always a partnership. And I just love that picture so much, I had to find a spot for it. Okay, so now I'd like you to get to work here. You can point your phone at this QR code, or if you're old school, you can use the paper on the end of your table and you can point your phone at that QR code. And once you are there, you'll be in something called a Jamboard. And this gives you a way, either right now or later in the conference, to be able to give us additional feedback. So once you're inside the Jamboard, you'll see kind of a toolbar, which if you're like me, you might have to take your glasses off to see because it's quite small. About in the middle of that, that suite of tools, there's a little image that is meant to look like a piece of paper with the corner folded and some lines on it. That's essentially a Post-it note. So on any of those Jamboard pages, you can put your comments or your edits using that tool. You don't want to use the text box because you don't want to change the question for all the other participants. You want to just use that little Post-it note image. And if you don't like being high tech, don't worry, we're using Post-it notes later. Real paper Post-it notes and pens. Yes. In fact, if you'd like Post-it notes right now, you can have them right now. So raise your hand if you'd like Post-it notes right now. So the prompts there are you can comment or edit or update the definition. You can share your thoughts in relation to the definition as to what you like, what you wish was included, and what if you were to consider this other thing. Okay? We'll come back at the end of the presentation and we'll pull that all together. So there's a little arrow that goes to the right at the top that lets you move to the next page. Okay, no, you hold on to your Post-it notes if you want. All right. I thank you in advance. Thank you in advance for your help with getting us that feedback. Jenny?
Okay. All right, so as far as the current evidence is concerned related to who may benefit, am I on? Okay, it's people who can't independently move in and out of a position when they're in supine, when they're lying on their back or lying down. Folks that are at risk of secondary conditions that arise from limited movement. People with cerebral palsy, spinal cord injury, multiple sclerosis, muscular dystrophy, spinal muscular atrophy, ALS, and then people post-cerebral vascular accident. Now, people with cerebral palsy are the ones that have been in the studies the most, and we have the most information about, but all of these populations have been in a study or two at least. Additionally, as far as who may benefit, we added Thank you. There we go. People who have independent mobility yet want to counteract some of the asymmetrical postures that could lead to body shape distortion. All right. And over the next couple of slides, I'm going to report to you some information about what the outcomes have been related to who may benefit. And it's from peer-reviewed studies that have either been published as abstracts or full papers. So those of you who have your heads around publications and you don't see an author mentioned here, keep that on your feedback list because we want to hear it if we don't know it exists. By the way, all of these are first author only because we just didn't want to have too many words on a slide, but the full reference list has the other authors. Okay. So as far as body shape distortions, this is where we have the most evidence or the most promising evidence. There's been findings that the body shape distortions can either be reduced or prevented. When it comes to sleep function, it depends on the study design, how long they've had the intervention, and other criteria. In some cases, sleep actually improves, and in other cases, there's no change. Same thing with pain symptoms. In some cases, the pain actually decreases. And in other cases, it's unchanged. Generally, for when we're investigating muscle tone, that tends to improve. As far as daytime sitting tasks and people being able to help, caregivers being able to help somebody with ADLs, there's been some improvement there for the studies that have looked at that. There's also been a couple of studies that looked at whether or not using lying postural care can affect the use of other interventions, and they did find that it could potentially decrease the need for surgeries or orthoses types interventions, or botulinum toxin too. As far as quality of life, there hasn't been too much on this, but it looks like there could be some improvements, trends towards improvements in that area. For respiratory function, the studies so far have not shown any significant change. And then for pressure distribution or disbursement, it depends on the study. One study looked at people that were able-bodied, and they just did a point in time where they compared people in line, sideline, and prone, I think. And so it depended on the position they were in as far as where the peak pressures were. And in some cases, the peak pressures were higher. In some cases, they were lower. And then the other study showed that overall, the distribution of pressure was spread apart through the body because of the whole body positioning. Okay. And by the way, we haven't mentioned it yet, but it is all about all ages. If we haven't said it, but this isn't something just for children, it's something for all ages. Okay, in our position paper, we're using a couple of structures to help us be able to talk about lying postural care. One of them is the HAP model, the Human Activity Assistive Technology model. And that model looks at the intersection between the person doing the activity. Sleeping is one activity that's very directly related. And it also looks at the context the person is in and the interaction there, as well as the technology. And technology is last in the model because the idea is we might not need technology in general, so we really have to think about everything else first before we decide to use technology. Okay. But it does explicitly allow us to look at technology, which other models don't. And then as far as when we're talking through the document about considerations, we really felt it was helpful to use the service delivery model so that we didn't miss anything and we could capture what was needed to be thought of at each stage. So the World Health Organization for the skills package, the skills training package, has a really nice service delivery model. And then the Cook text, which is used by RESNA related to the exam, has another description. And so they're similar, but we chose to use the one that's in the Cook textbook. So it's referral and intake, followed by the assessment process, evaluation, matching the person to the user, or I'm sorry, matching the device to the user, the decision-making process around what you're going to choose for the person to meet their goals, implementation, so the actual fitting setup process, facilitating performance, which facilitating performance is really about after you've set up and fit the device, making sure that the person's goals are still being met, having that immediate and ongoing follow-up, making sure that you make adjustments as you need to, and also just looking at their overall performance using the device to make sure that it's matching their goal needs. And then evaluating effectiveness, so those outcome measures. Okay.
So I told you that we were going to have things for you to do, so now it's time to get busy. We are going to have you use Post-it notes. Please, if Post-it notes are near to you, share them with some of the other people down those long tables or behind you so that everybody has access to the Post-it notes. So we have Post-it notes and Sharpie markers. Have the markers been handed out?
There's about 4 or 5 markers at each of the big papers, but if you have a pen, you could bring your pen along too.
So we would like you to put your input on the Post-it notes. We've chosen 5 steps of that 7-step delivery model that you just saw a short while ago: referral, assessment, outcome measures, matching device to user, implementation, and facilitating performance. We have our also artfully attached pieces of paper in 5 different places around the room. And we would like for you to put your comments and your suggestions or ideas, feedback on the Post-it notes. So what kinds of considerations would you think need to be considered at different service delivery steps? And just ideas and examples, it might be pain, it might be family and caregiver situations and issues. It might be the person's culture. It could be many different things. Those are just ideas to kind of get you going, things that you would be thinking of as you look at these different service delivery steps. And then once you've got something written down, or some things written down, I hope, you can go to the large sheets of paper and put your Post-it note under the category where you think it belongs. Okay? Now, meanwhile, just to keep us moving, because we don't want to run out of time.
Also, if you are a Jamboard person, if that was working for you, there are sheets there too, so you can do it there. We know not everybody can.
If you want to do the Jamboard, you could. We'll get it there. But we decided to go low tech here because it's kind of more foolproof. There aren't tech problems. So, okay, over here we have matching device to user. This is assessment outcome measure. Back there is referral. This one is implementation, and this one is facilitating performance. Just to give you, but we realize you'll have to maybe wander around and figure out what's where. So in the paper, we are going to include 4 case studies to share examples of lying PCM in action. And I'm just going to flip through these just to see if it can kind of prime the pump a little bit. It might help you be thinking about some of the people that you've worked with. So as examples, these are the 4 categories that we are going to be having a case study in the paper. This little guy is actually Kourtni's nephew, Bastian, with low tone and low tech around the home, what she put together for him when he was about 1.5 years of age. He was unable to move himself independently. And what we really want to bring forth is that this child has not mastered supine lying in symmetry, balanced lying. We don't need to know if this is just a delay or if it's a permanent disability. We just need to address this issue, because even if it is just a delay and they're going to move on from this, there could be negative consequences if he's spending lots of time lying in this position. This is an older child, Kourtni's nephew, Carter, actually. And the picture on the right was taken the day that she read her first article on 24/7 posture care management, which I guess was something that I had written someplace. She didn't know very much at the time, but what she shared is that she found things around her apartment because she just felt that this was so important to do for Carter. And she went to work. Carter has been a huge inspiration to Kourtni, and she lost him several years ago, but he continues to really inspire her. So he was unable to move in and out of symmetry and supine as well. And this is my client. You've already seen images of Jim. Jim has multiple sclerosis and chronic pain, and changing the way he was sleeping at night drastically changed his chronic pain situation. So he was able to go off meds, also improved his sitting posture. And this guy is my dad. And my dad died 1 week ago tonight. He was 93 and he had dementia, but this was at his 93rd birthday party almost 2 weeks ago. And I had already decided I was going to share this image because we wanted an image of an elder who is still moving around, but who is becoming kyphotic, which is something that so many of us see. So I'm really glad to be able to share this picture of my really darling dad. Yeah.
So I want to give you guys a minute to stand up, move around the room, take your Post-it notes to their target locations. I think you're looking for this one.
No, it's another, there, that one.
This one.
That one.
Referral, assessment, outcome measures, matching device to user, implementation, and facilitating performance.
Whatever's up there, we can type later. We just need notes on like what suggestions people say, especially during the Q&A. Okay. Yeah. Something that somebody Have you got research? Not in the service delivery, but if you've got research, right here. Awesome. Yep. Thank you.
Same training.
That's a great session. Hello, hug friends. I love you. People are kind of dying down on the delivering the post-it notes, so I don't think we have more to say. So I know it's like that's crazy.
And we are trying to use those images, and you know, those are the last two good pictures. That's not the good yesterday. I love them. It's not how we look.
Yeah. That's a good. Yeah. Thank you, Sherry. Okay. Yeah. Okay. Well, okay. Can you try again on that handheld mic? So we can go around and read the people's post-its?
I'm afraid it's going to cut out. We can try. I don't know.
We try one last time.
Yeah, you can try again.
Give it a Hail Mary.
Sure.
On Saturday.
Optimism.
And, yeah, all of it. And that's it's not a tragedy when a man dies, but it's still sad.
Kevin, you gonna pray for me with it?
I will.
Do you think it'll work?
Yeah, it seems to be this intermittent, like, cutout, so let's hang with it. If we miss something, maybe it'll, I don't know why the interference is happening, why it's dropping. It's definitely not a battery, the battery's brand new.
The first thing I heard, it was one of the things I learned on Facebook. I saw pictures of it in front of my post. It's like, only one of the people in this picture is left. I'm like, no, Bobby's still around. And, well, no. I'm saying training a lot, but
Oh, are you ready for me? You should just pick one board and just speak to one board. Okay. What do you think? Which board is okay? I don't know. Are you doing the walk? Thank you. Love it. The steps. Yeah. Or Jamie, 1 and 2. I will do 1 and 2 assessment and then matching because I walk back that way. Do assessments and then go back. Yeah, because then I'm walking. Okay. With my steps too. That sounds good. Yeah. Okay, ready, Kevs? There. Is it? Okay, I've got the tricky microphone, so we'll see how that turns out for me. Otherwise, you're all doing karaoke. Okay, so looking at assessment outcome measures, I'm just going to choose a few things because there's some beautiful handwriting here. So, yeah, that was me stalling. So assessment and outcome measure. What we got here is culture. Someone's kindly put that there. What to take measurements of. Amen. And then it's got pain levels. I'm going here to sample devices and training. Insurance and funding, our favorite word, the F word. Okay, the other F words. Trial of equipment, inability to move in and out of symmetry. Love this. Okay. English speaking, time. I'm thinking more language here, maybe respiratory status. Okay, I'm going to get my steps in so you can watch me walk over. Okay, it's gone. Okay. Continue. All right. Is it back? Yes. All right. I don't want to shout you out, but I'm going to shout you out. Okay, matching device to use your whole body positioning system. Matching, we've got training here. Technology available around the home. Types of mattresses powered or non-powered. We quite like that when we saw that. FDA approved devices. Implement trial of equipment. Data collection. Video. I love this one. Video and picture. Matching is funding. Oh, there it is again. No. Matching. Yes. Matching device to user difficulties of devices to trial in clinic. So that's quite a big stumbling block that we find is you don't have the things. We need all the things to try. So you don't have the things to try in clinic to do the matching of device. Texture, ease of use. Someone's been studying the RESNA equipment stuff there. Let's see, queen size bed, spasms. Understand diagnosis, progression or regression. And then consider the medical needs. Yeah, so a whole lot of good stuff here. Okay, I think my microphone time is out because, thank you. Thank you. Okay. Oh no, I'm back with this. Is this one on, Kevin? Yes. Are you praying? Yes. Okay.
Okay. So this is where you start.
Okay. Sorry, Kevin. Thank you. All right. I was praying a little bit later as well. So in terms of the definition, so Jenny, do you have any updates for us on the Jamboard?
I'm trying to open it as we speak. Anybody in it?
Okay, so please hold for Jenny and the Jamboard. So we kind of went for, that was great, right? It's like a band. Okay, so we kind of went through, I'm so sorry, Jenny.
I like it.
They gave me a microphone and I'm lost. So we've done activity 2 already where we served up some of the service delivery considerations, but I think our Jimmy Jamboard is not playing. And this is the benefit of going low tech. Okay. I could do that. Oh, could you share?
Yeah, sure. It says implementation, curious how to best measure compliance with protocol or recommendations.
You're amazing. Thank you.
Good enough.
All right.
That was the only comment.
My courier is on her way.
Okay, and then it looks like there's actually a few more.
Why, thank you. Do you mind sharing?
Not at all. It looks like one says, I like the language around skillful placement. I like the language around skillful placement.
We can repeat it.
The language around skillful placement?
Yes.
Okay.
The next one says, example, I like the wording co-create because it's important we show it's a team effort.
Yay. I also like the language co-create because it shows that it's a team effort. I feel like I'm translating for you now, and I'm not the best person with this accent either. So
The next one says, I like this definition. It states it's therapeutic and skilled for a person's increased function.
Everyone got that? Therapeutic and skilled for a person's function? I'm not just keywording you.
Empowered makes it sound like a choice versus an essential component of a person's health and well-being.
Okay, so empowerment, to summarize. Thank you.
And that was like the comment.
Thank you so much. Wow, super plant. Thank you for coming. Okay, unplanned. Okay, I have staff apparently, so thank you for holding this, Trish. Okay, implementation, setup, delivery, and fitting. Caregiver carryover. ATP, service tech delivery. Implementation time. This looks like transport space and dollars. Okay, living environment, so group home with changing caregivers, so that rates of attrition. Multiple visits, equipment trials, payment for OT services. I'm going to say OTPT because you're family, although it is OT month, so it's good. Whoop, whoop. Who is responsible? Can this be part of outpatient treatment, separate eval, and then billing code? Ease of use, there's that RESNA terminology again. MAT eval, teaching parents, caregivers. I think I've pretty much got them all. Discovered my vision isn't what it was. Okay. I'm going to be up front too. I'm going to be with you. Are you getting more? Shall we do one more? Sure. Thank you, Trish, for putting the mileage in. Oh, they had me shouting. No one was complaining when I was shouting. Okay, so Trish is coming with a very noisy paper. You're going to hold again? Thank you so much. Fabulous. Okay. It's stuck to you as well, which is great. Okay, so facilitating performance. So let's see. This looks like pain, and it's got the word listening, so I'm not quite sure. Pain, listening, facilitating something, training caregivers, family training, assessment, follow-up, regular school follow-up with professionals, who to contact when review is needed. So, yep, the carryover. It is. So follow along if you're doing the ATP language, the follow along. There's more. Oh my goodness, this is the best presentation where people do stuff for you. Okay, referral and intake. Lying is an important ADL activity. That sounds like an OT. Thank you. Okay, educating PCPs, physiatrists, general therapists, special educators, and LTC staff. Maybe if I squint this one. Question of present state. I'm not sure if that refers to the state geographically or actually the state of the person. So that one is unknown for me. But if it's state-wise, my geography is awful, so I'm out. Okay, let's see. Funding again. Thank you. Getting information from family about their expectation, I'm going to think, of the device. So again, assumptions and expectations. The form of payment, there it is again. Other equipment payment goals, reason, and medical status. But I still want to say status instead. Budget reimbursement, referral, and caregiver concern, given feeding at night while in bed. Okay. And liability, this is the one, who holds liability. That's a good one as well. All right, so there we go. Okay, so that concludes my reading of post-it notes. So we know that I've passed English language 1. Okay. All right, so now we're going to start wrapping it up. We're good? Do you want to do one thing?
Yeah, I got just one thing. I'm so glad that many of you mentioned funding. That's something I forgot to mention, that with this service delivery process, they talk about funding happening in 3 different phases of the process. So you will help us with your comments figure out what phases your comments belong in. So thanks for mentioning those. That'll be really helpful. And then I think we're going to open it up to questions, right?
Okay, I'm back holding this thing again. Okay, so just to summarize, just quick conclusion here is there's obviously a need for a position paper. That's kind of why we're all sat here. Thank you for coming. Also want to complement the existing RESNA papers that are there, and we want to include the evidence and also best practice recommendations, the case examples, and definitely following the Cook et al. 2020 service delivery steps, the HAT model, and then also your incredible feedback from today. Okay, so we'd like to also make this paper available for review and comment, so watch this space. Am I doing this last Jimmy Jammy as well? Okay, so this is the same, I must say Jimmy Jammy board link. This is the same Jamboard link. When you're leaving and you maybe didn't scan the code, or you're like, what did they say? There are also papers on the doors as you exit. If there's any other point you want to make, so this will be page 10 on your Jamboard. So if there's any point you want to make, maybe you wake up at 2 o'clock because a.m. because you're uncomfortable and you're thinking, what did they say about sleep positioning? What is that about lying? Then make your point, put your questions that you've still got on there. And if there's any ideas or concepts missing that are keeping you up at night, put them on the Jamboard. Okay, the gift that keeps on giving. Right, so we just wanted to share that these are teeny tiny references, and if you can't see them, that's okay, because they are as part of the handout. You have not failed your vision test. You will not be deported. Okay, so these are our final references. So would you like to join us for any Q&A? So any questions that anyone has? And I'm going to step away from this microphone right now because I think I've had enough time, and you're going to have my accent, so no one needs that. Any questions, please?
So you're
Can I
talking
s- can I s-
you're talking about the
Can I speak to that?
yeah.
That's a really good question. I'd like to speak to that because I was voting in favor of the World Health Organization once, to tell you the truth. But we thought that since this is a RESNA paper and the Cook and Hussey text is the recommended text for people who are studying for the ATP exam, that influenced our thinking. But that's a really good question, Sarah.
Along the same line, how different are the two models?
So how different are the two models is the question. And there's a lot of overlap. Yeah, I think there's probably, I think there's 7 or 8 total maybe on the one in the Cook text. 8? Okay.
7 in the Cook and 8 in the World Health Organization.
Okay. But yeah, there's a lot of overlap. There's a little more specificity, I actually think, and the one that is in the Cook text, as far as a couple of the different steps of the service delivery process. I'm not speaking very well to the whole of it right at the moment, but there's a lot of overlap.
Lauren?
I'll repeat it. I'll repeat it anyway. But. Yes. So if people didn't hear that, I'll just repeat that our title says 24/7 postural care management. The suggestion is change the title to Line Postural Care Management so that it truly reflects what the story is about. Great suggestion. Thank you. I think that's a yes. There won't be too much discussion about that, I don't think, on our end. Okay.
Other questions? Comments?
I just want to say I've done position papers before, and I know the work that you guys have done, and I know it's a labor of love, and I want to thank you for doing it because it needs to be done. This is one of the hardest things to get funded for. So anything that we can get this written, I know that third-party payers really respect RESNA's position papers, and you really do.
Thanks, Jessica. So Jessica said thank you for the work that we're doing, and she knows it's a lot of work and it's needed. My summary, if it's adequate. Yeah.
Can I speak?
Yeah, because I couldn't hear. Can you repeat it though?
Yeah. So let me repeat your question so everybody hears, because I understand exactly what you're saying. So our friend is pointing out that he's having a little bit of trouble with our choice of the Cook and Hussey text service delivery model over the World Health Organization service delivery model, because the Cook and Hussey text is very American and very focused on the ATP process. Actually, I'm a whole lot more familiar with the World Health Organization one because I've been in ATP for so long that I never really used the other text. So we did debate about this quite a bit, and maybe we need to talk about it some more. I was the person who was in the camp of let's use the World Health Organization. Other people in the group had a different idea. We did discuss it and debate it, and maybe we should discuss it a little bit more because we recognize that RESNA does have worldwide recognition and is part of GATO, and that people may look to this. And a number of I think most of our position papers with RESNA now are actually translated into Spanish, so that they are more accessible for people outside the United States? I think it's a really good question, and I'm glad that you've brought it up. We'll take it seriously. David.
Could we have a little bit of this discussion within the paper and not really choose one or the other, but these two different service delivery models exist in the world, and here's what we think you should do.
Do you all hear Dave's idea? I think that's a really interesting one because really the vast majority of people in the world are going to be familiar with the World Health Organization, the 8 steps, and not familiar with the Cook and Hussey ones. Yeah.
In the textbook I was part of, we did that very thing. We acknowledged both and said in this text we're choosing to use this one, right? Acknowledging that both exist, explaining both, but then at some point you just have to use one in the language of the other.
Okay. Thank you so much for bringing thank you so much for asking that question. It was a really good one.
I think one of the important things about the service delivery model is it provides an organizing factor to the paper itself so that at each step of the service delivery model, we can elaborate what that looks like with this particular assistive technology. So debate aside, the importance is to provide a framework for the reader to be able to process the information in an organized way that they're going to then be able to take and apply.
Questions? Anything else?
I will repeat it. I'll do my best.
Not very loud.
Mm-hmm. Mm. Yeah. So especially in the United States. Yeah. So what's your first name? Andrea works with very young children, babies. And we have a lot of concerns in the US because of SIDS, sudden infant death syndrome, and safe sleep. And so will that be addressed in the paper? And thankfully, Jessica's taking these notes because I think the answer is going to be yes in some fashion, because we are going to need to talk about ages.
Can I say something? I'm glad that you brought that up. I've often been asked that question when I've been teaching on this topic. And one thing I do like to remind people of is that the American Academy of Pediatrics talks about sleeping on the back up to the age of 6 months. I know that that's still not covering the kids under, but that's what I usually try and share with people, is that if you're feeling really, really worried about this and those recommendations, that the back to sleep thing is only for kids under 6 months, for what it's worth. I mean, we could talk about this a lot more too, but I think we need to address that in the paper.
You might want to check the guidelines though, if they've updated them.
Have they?
I just found out that they've changed them. You can't elevate a kid above 10 degrees now. So there's new stuff, and that goes to age 2. So there's new guidelines that just came out with one of my positions.
What the name of the guy?
So could you share that with us, Lauren? Can you give us the, not right now, but just, us.
I haven't gotten a copy of the new guidelines because I haven't seen her since this happened, but
Yeah.
I'll get a copy now.
Yeah, you know us, and just send us a link. That would be really helpful. Thank you. I think we are out of time.
Thank you so much for your input. We're out of time, although you do still have the link if you think of some more things later.